Hi, my name is Nicholas Campbell. I'm an internal medicine resident at University of Tennessee, the Chattanooga campus. This is our case report, Trying to Stomach Myeloma. It was created in part by Juan Malpartida and our attending Dr. Michael Davis. So the objectives for this is to identify a common presentation of gastroparesis, know the test to diagnose gastroparesis, diagnose multiple myeloma, and recognize that multiple myeloma may have other manifestations, including but not limited to CRAB. So this is a 51-year-old male who presented to his PCP with intractable postprandial vomiting as well as left lower quadrant abdominal pain, bloating, early satiety, and constipation for a while. Only other symptoms he was having was fatigue. His vitals were essentially normal. Physical exam notable for poor dentition, dry mucous membranes. And laboratory studies was significant for anemia of 8.9, normal iron studies, and calcium of 13.5. BUN was sturdy and creatinine 3.0. CT to evaluate his abdominal pain was obtained in it, and within normal limits, no acute findings. And he would be admitted for symptomatic hypercalcemia and AKI and anemia of unknown origin. So for his hypercalcemia and renal function, he was started on IV fluids and calcitonin with incremental improvement. Our first figure here shows 13.5 calcium, serum calcium initially, and with the IV fluids and calcitonin, it would incrementally decrease. You can see calcitonin at the bottom right here, and then when the calcitonin was no longer given, he had a little increase, and then it would be administered again, and he decreased down to 7.2. With the IV fluids, his creatinine decreased from 3 to 1.8. So regarding the constellation of hypercalcemia, renal failure, and anemia, he would be evaluated for multiple myeloma, and the bone marrow biopsy confirmed this. He received a skeletal survey, which revealed lytic lesions. You can see them on the outside of the skull right here and on the L4 vertebra, completing the typical CRAB presentation or CRAB. So despite successful treatment of his hypercalcemia, his GI symptoms persisted, prompting more investigation. An EGD was obtained and a gastric emptying study as well. The EGD revealed gastritis, but no obstruction. And then the gastric emptying study revealed markedly impaired gastric emptying, which goes to our third figure right here. And you can see these lines right here. After 240 minutes, he essentially had 0 emptying. He was diagnosed with gastroparesis. He was started on a modified diet and metoclopramide. He had significant improvement of his symptoms before discharge, and he would follow up with hemonc after for a stem cell transplant. So the beginning of our discussion reviews how chyme or food is digested and how it's emptying in the stomach. When one is evaluating for gastroparesis, it's essential to rule out organic causes such as physical obstruction, as we did with the EGD, and correcting electrolyte abnormalities, as we did with the calcium. The cause of the patient's gastrointestinal symptoms was initially attributed, like we said, to hypercalcemia, which can cause nausea and constipation, especially over 12. However, that did not help. Regarding the pathophysiology of gastroparesis, it's pretty interesting. It's, we always think, or we typically think of gastroparesis to be associated with diabetics because of nerve damage. However, it's actually suspected to be multifactorial, with proposed mechanisms ranging from dysfunction of smooth muscle cells, ICC, or interstitial cells of Cajal, nearby macrophages and/or myenteric neurons. One study actually with mice with delayed gastric emptying and diabetes, it was actually found to be associated with increased pro-inflammatory factors. The thought was there was decreased inhibiting inflammatory factors by the nearby macrophages and decreased ICC. Other things that are considered is actually direct nerve damage by myeloid deposition. So pretty interesting case where multiple myeloma and gastroparesis presented at the same time. I hope you enjoyed it. Thank you.